Hi, everyone. I know that was kind of a bizarre start, but we are getting our tech in order. I am Jackie Zimmerman. I'm a longtime IBD patient and advocate. I am here with Dr. Neil Nandi, who is a GI out of the University of Penn now. Yeah. He's also one of my favorite all-time doctors, so I'm super excited to talk to him tonight. How are you, Dr. Nandi?
I'm great. How are you? It's been a while. Thank you for
I
having
know. I wish we were meeting under other circumstances.
me. Me too. Me too. Me too.
We're going to be here tonight talking about your questions about COVID-19 and IBD. We're going to have a Q&A, so if you have questions, feel free to put them in the comments and we will get to them. And I also wanted to mention that Galley Health, the wonderful people putting this Q&A on for us, they are launching a separate news feed in the Galley Health app specifically for news related to COVID-19 and IBD. It'll be reliable and comprehensive and like everything that comes through Galley Health. So it'll be launching soon, and check that out in the app. But let's get to the info tonight. Dr. Nandi, I know you've got some updates I think that you want to share with us.
Yeah, tonight, just to kind of set the tone, this week was a big week for us in the US in our role and as IBD patients, because we had a lot of good IBD summaries as how COVID affects our IBD patient. I strongly encourage our community to tune in to Monday night's webinar, where Doctors David Rubin and Andrew Grossman reviewed kind of the latest stats and updates about IBD on the Crohn's and Colitis Foundation's webinar. So it was an excellent webinar. I highly encourage you to go there. Rather than kind of reminisce or summarize that again, tonight's webinar we designed so that we can answer, even more questions that have come up since, or that you've been thinking about. How does COVID affect me and my life? We're going to try to give you some practical answers. I'm going to do my best, and likewise, I'm also here to learn from you. We are, Jackie and I as well. So if you have good tips and ideas, hopefully those will come back. I'm going to share them with the community too.
Absolutely. Okay, I think this is a burning question. Do we know officially how many IBD patients have been officially diagnosed with COVID-19? Were they hospitalized? How are they doing now? What do we know?
Sure, we actually do have some numbers, and I'll share them with you. What I'm going to do, I'm going to go ahead and do a screen share and kind of share a couple of numbers. This is from the Johns Hopkins COVID-19 Resource Database Center. Hopefully you should be seeing this on your screen. So this is the total number of cases estimated worldwide, over 526,000, with over 24,000 deaths worldwide. This is not IBD patients. For IBD, there is a secure registry called Secure IBD. And this is just an estimate. About 41 cases worldwide have been reported. There are cases that may have been underreported. Only about 10 have been hospitalized, and we don't know yet in terms of how severe those patients are. 2 deaths have been reported. Now, this is a secure HIPAA secure registry, and we still don't have a lot of data or metrics on this, but at least this gives us a snapshot. In the US, there are about 13 cases. 8 of them actually were reported in New York last that I had been able to check. So 13 in the United States, about 8 in New York. And to the best of my knowledge, there has been no report of deaths of an IBD patient from COVID in America, to my knowledge. So what does this mean, right? What does that 41 cases mean? That's a small number. It's an important number because we don't want anybody sick, of course, right? But it's a very small number. We don't know if IBD patients are at increased or less risk because we simply don't know enough about COVID in IBD patients yet. Now, as of March 9th, there was a publication of a 20,000 IBD patient database from China, and none of those patients had been reported to have COVID out of 20,000. Now, that it can be for a number of reasons: under detection, under diagnosis, or because the government there was very swift in implementing quarantine and self-isolation measures. So we don't know. But we're going to talk more about medications and IBD through this conversation, but that should hopefully give some insight. There's a small number of cases, but there are cases. In my opinion, I think those just happen to be more casualties, more contact not casualties, that's a poor choice of words, but more sick context, just because everyone is bound to get sick because it doesn't discriminate the virus. I can't say that we're at tremendously increased risk, but granted, we are on immunosuppressed medicines. We'll talk about that more.
Do we know anything about those couple patients maybe that have died, if they had other comorbidities, or is it sort of, we just know that the facts of they have IBD, also COVID-19, and they happen to pass?
Yeah, we just happen to know those two. I'm personally not privy to the details of those, and I'm sure in time those will be more reported in depth. Again, let's just kind of talk about COVID and why we're scared of it, right? We're scared because it's contagious. 80% of people, though, who get it are going to have mild disease, okay? And 20% are going to have more significant illness that's going to require medical attention and or hospitalization. In the general public, we know about 20% those are going to get hospitalized, are between ages 18 to 44, and another 18% ages 44 to 54. So people may get hospitalized, but that's not the mortality. We really don't know the true mortality of this virus yet. Estimates anywhere from 3 to 4%. However, because we're not testing enough, we don't know that denominator, that bottom number. So we really can't tell you what the final actual mortality rate is. So it's too early. By and large, most people may get infected, or so I say many people may get infected, but most people are not going to have significant illness from it.
So when talking about, we'll call them like the normal, healthy people, no underlying conditions, who are getting this and are getting sick, would that be like somebody with IBD who's not on an immunosuppressive drug, or are IBD patients who are not on an immunosuppressive drug, are they in a different category on their own?
Again, we really still don't know. There's a lot of well, let's talk about medications right now, right? That's what makes, that's what our biggest concern is if we're on any immunosuppressives. Our biggest concern when it comes to immunosuppressive drugs affecting the Crohn's and ulcerative colitis patients are steroids, okay? Steroids are magnitudes greater in suppressing the immune system. And we have an increased risk of infections, okay, from it. But, biologics and even small molecule medicines were developed in order to blockade a portion of the immune system, not the majority of the immune system. It's so that we can avoid the increased risk of infection that comes along with steroids. So that should give us comfort. It gives me comfort to know, because we know exactly how our biologic medicines work. And so we're, again, blocking a portion of the immune system, not much of the immune system. That's why there's a decreased risk of infections with our biologic drugs in contrast to steroids. So if you are on one of these medicines, these self-injectable or IV medications, yes, it's an immunosuppressant, but it's not as significant as steroids. So of course, Jackie, you're thinking, what about patients on steroids, right? What should we do, right? That's what you're thinking out there. So if you are on a steroid, okay, or you're on a biologic, we don't want you to stop your medicines. You know why, Jackie?
Because the risk of a flare is bigger than your risk of getting COVID-19?
That's exactly right. Your risk of flare and everything that comes along with it. If you flare, then you may require more steroids, right? Or hospitalizations or emergency room visits, exactly the places where we don't want you to be, right? Your doc doesn't want you to be there because you could capture COVID or some other infection, right? There's many other infections still around that we have to fight off. So we want you to stay on your medicines, especially if you're doing well. And if you're not doing well, one of the questions we got here from one of our friends on the internet was, is this the right time to change a biologic? Well, if you're not doing well, talk to your doctor, okay? And ask, is this the right time to change or not? Because if you're not doing well, then it makes sense. We should consider changing about your medicine with your doctors and your consent. Because again, we don't want you to be on steroids, flare, go to the hospital. If you're on a steroid dose, it's important, again, talk to your own personal doctor and make sure that you have a conversation with them about how to taper or to what biologic agent you can taper to, because we don't want you to catch an infection like COVID or flare.
So speaking of biologics, are all biologics in general considered immunosuppressive?
Yes. Yes. I had to think about just to be thorough, but yes. biologics, and we refer to them as their antibodies. And so they block a portion of the immune system. So yes, they are immunosuppressive medicines. But again, not all immunosuppressive medicines are created equal. I should go on to caveat much of this by saying every patient is different. Every one of you are unique. And therefore, what we talk about here is information to help arm you and empower you, educate you, and your family and friends. You need to have an individualized, tailored discussion with your personal physician, your treating gastroenterologist, and understand how this medicine and how this applies to you uniquely.
How does all this information work with our patients, our IBD friends who are working in hospitals right now? So we have people who are on the front lines. What can they do, especially with the lack of the safety equipment that they need?
Yeah. So I think you're asking, what about our IBD healthcare workers, right? So we have our healthcare frontline workers, and then that subset that happens to have inflammatory bowel disease, and another subset that happens to be on immunosuppressive meds. So here's what I say to any healthcare worker, IBD or not, thank you for being out there and doing what you're doing. All the healthcare workers, doctors, nurses, PAs, dietitians, physical therapy, OT, everybody hands on deck, including the custodial staff, security, everyone in the healthcare workforce is putting their lives on the line right now. And that's why it's so home for other people to stay at home so it doesn't distribute the infection, so healthcare workers get it. If healthcare workers succumb, there's nobody who's going to take care of the sick, right? So we can't afford that. So thank you for what you do, because we have to do it. Otherwise, nobody else is going to do it. So now, if you happen to be an IBD patient and a healthcare worker, you have to examine the environment in which you're in. Some people are exposed to more infections because they're inpatient workers as opposed to outpatient workers. They might have different environmental risk factors. You need to talk to your supervisor if you feel that you're at risk to catch an infection. Okay, let's make it the easy scenario. You're on really high dose steroids and you're in the ICU, let's say. Then that would be a much easier situation in which to say maybe you need a letter from your physician or talk to your supervisor. I'm sure they'll be understanding to say, you know what, maybe you can't work in this environment. Maybe you need to either work remotely from home or perform a different duty, triage, some type of administrative work that's critical to the good fight. So I would say conservatively, talk to your supervisor and see if you can change your duties or look at the risk factors for you. Your individual doctor can also understand what your risk is to catch COVID or some other infection based on your medicines and your health history.
Asking for an alternative position is, I don't know why I didn't think of that, but it seems like, yeah, totally do that. More immunosuppressive questions.
Sure.
If you have an ostomy or a J pouch, are you inherently just naturally more immunosuppressed, or does that not really factor in once you are healed and maybe not on any medication related?
My answer is no. There is no reason to believe that having an ostomy means that you're at an increased risk of infection. It's not an immunosuppressed state by and of itself to have an ostomy. Many people do for all sorts of reasons who don't have IBD, and they do not have any increased risk of infection to my knowledge. So if you have an ileostomy or a colostomy, you're not at increased risk for COVID to the best of my knowledge.
Very selfishly, that's good information to have because I have a J pouch. What about other drugs like Imuran or 6-MP? What do we know about that?
Again, we don't know a lot. It falls into the category of, it's not a biologic, but in immunomodulators like 6-mercaptopurine and azathioprine. These medicines are immunosuppressants. They do suppress the immune system. Again, I don't believe they do not suppress to the degree that high-dose steroids do. But they can be immunosuppressives. However, if this is part of your medication armamentarium, what's helping keep you in remission, helping you heal, I do not recommend that you stop it. Continue it. If you have doubts, talk to your doc. But right now, the IBDologists around the world, we firmly believe that if you are doing well, stay on your medicines. It's far more important than risking you flare, again, going to the ER, going to the hospital, and high-dose steroids.
Does that play in so in general, when you have an autoimmune disease, let's say without meds, your immune system is running high, the meds kind of help bring it down. Based on everything you've said, it sounds like unless you're on steroid or a high dose steroid, your risk is not terribly high, we'll say, right? Just from naturally being on a medication with a weak immune system, or is that not right?
So we think that a dose of 20 milligrams of prednisone or higher is more immunosuppressive than a dose of 5, 10, 15 milligrams. That doesn't mean if you're at 20 milligrams, you just stop cold turkey. You should not do that because you can have steroid withdrawal effects. Certain hormones in the body can go awry and you can feel lightheaded, pass out, low blood pressure. So below 20, we think is a safer dose to be at, but 20 and above still has immunosuppressive effect. So you have to be careful of the dose. Something I didn't fully answer was if you are on a dose of 20 or higher, what should you do if we think that's a suppressive dose that you might get COVID? Well, the best thing for all of us, right? Each and every one of you and myself is what we're doing. We are social distancing or distantly socializing. I like distantly socializing. If you minimize your exposure risk to the virus, you can't get it. You know, that's the best thing, right? Prevention is absolutely key. So if you are on a higher dose of steroid, 20 or more, then certainly prevention is all the more paramount.
Here's something that I see a lot of people talking about in terms of IBD. What if I am sick, IBD sick, and I have to go to the ER? Like, I know I got to go. What do I do? Do I go to the ER? Do I call my doctor? What's the plan?
So emergency is different things to all of us. If it's true emergency, you should definitely go to the emergency room as fast as you can or call 911. Right now, medical resources, all these things are under a strain in certain parts of the country, primarily the Northeast New York city, bless their souls, and not as much in other parts of the city. So if you have a true medical emergency, life-threatening, you call 911 or you go to the ER. Below that, probably the best thing to do is to give your doctor the heads up, okay? Myself, all my colleagues at our university, all the physicians, majority of the physicians in the country are doing telehealth. But what's never changed is the telephone, right? So we're used to having one of us be on call 24/7. And I think I comfortably speak for my colleagues. We are ready to do whatever it takes to take good care of you. So if you have an urgent situation, you're scared about going to ER, but it's not quite that 911 call, call your doctor. Practices usually have a physician on call 24/7. And we are relying on patients to call us for emergencies or urgent situations. And we can also segue into telehealth and telemedicine and what to do about outpatient visits too from here. But we're also relying on everything digital in order to even see or talk to our patients.
I've seen some people with concern about getting through to their doctors. Everybody's calling now all the time.
Yeah.
I'm going to just assume this is one of those situations where you've got to use your best judgment. If you can wait a couple hours, maybe for a call back, wait. But if this is, again, a true medical emergency, do what you got to do, right?
Do what you got to do. Yeah, if it's a medical emergency, do what you got to do. And at the end of the day, you're the best person who knows your body. You know what's an emergency. And our IBD patients, our IBD community, they don't want to go to the ER. So if you feel like you got to go, I trust you when you know you got to go.
Yeah.
But if you have that ability to talk to your doc, it may help your doctor just by talking to you, asking you some questions, help prevent the need. Maybe they can treat you in a different way, right? Maybe they can even still give you an in-person appointment, in the office. Some offices are still making allotments for in-person visits because let's face it, telehealth is not for everybody and not for every situation, shall I say. So where there's a will, there's a way, but it's worth a call to your doc. But if it's an emergency, go to the ER. But Jackie, you asked a question, right? How do we make the most out of telehealth? Have you had a telehealth visit yet?
My first one is tomorrow.
Hey, you got to tell me how it goes. Okay, I hope it goes well.
I had a meeting with a woman today who is working on training doctors to make the most out of telehealth. And I'm hoping to actually help her with that process moving forward. So I actually wanted to like tell everybody there are people out there who care about making sure those telehealth visits are as good and as effective as they can be. Because using the technology is one thing, but knowing how to really interact with patients virtually is another. Are you hearing about this from your colleagues? Is it sort of like we're figuring it out and it's difficult, or we've got it?
I think it's growing pains. Everyone's excited. Nobody anticipated. Everyone has known that telehealth needs to be here, but we didn't anticipate it to come up essentially overnight. But yeah, people have been really excited at my institution. But it's growing pains. So we're all learning how to interface with it. I've had a very good experience the last 2 weeks that I've been doing telehealth. It's honestly mostly been telephone and not video, but starting this week, we'll be doing video conferencing, which I think is going to enhance the spirit, because it is, for me, if you know me, Jackie, and you do, it's a little impersonal to talk to it through a phone. It's very efficient, but it's a little impersonal. And,
Yeah.
when I can see you, I can know that, you know what, you've got a thick skin. There's more pain here that you're not describing. I gotta ask more questions here, so there's a lot that video can add. I'm really excited to hear that people are trying to help us become better at telehealth. I think it's here to stay. I think it's a much needed resource. It's a benefit to our patients on many levels. But just because we can talk to a camera doesn't mean that we can do it well, right? So it does. Some physicians may not like this because already we have to sit with a complex electronic medical record, type, talk to you, listen to you, and maybe handle the phone. So there's a lot of juggling parts. I look at it as a fresh challenge, and kind of grew up in a technology age. So I'm kind of excited to get into it. It'll never replace a clinic visit, though.
Related, but pivoting a little bit, I've seen a lot of people talking about infusions right now. And so stuff you can't do via telehealth. I personally had an infusion yesterday. I went in, the protocol was different, but it still was fine. I'm seeing people wonder if they can get their infusions at home. I've seen infusion clinics close and postpone. I think it's, regional, and it's, however the clinic works. But if you're somebody who maybe is concerned about going in for an infusion, do you have options, or is it kind of specific to the center you're at?
It's honestly specific to the center that you're at, how you get your infusions, whether it's a center or a home infusion. It's also specific to your insurance, what your other options might be. Right now, just to get to the heart of the matter, the question for our viewers that's being asked is, if I get a home infusion, can I catch COVID from our nurse? Or if I go to an infusion center, can I catch COVID just because I'm there and there's a lot of other patients around, a lot more foot traffic? The answer is it's possible. We don't know how much of an increased risk we are or not. We suspect it to be very, very minimal. What you should feel comforted is this: one, each institution, whether in each environment, infusion center or home infusion, they're all taking extreme measures to ensure that their nurses, their healthcare givers, are protecting themselves, are sterilizing, are washing hands frequently. They take extreme care to make sure that they themselves are healthy. And if there's any doubt, then they isolate themselves. But we know, the healthcare, our nurses, I know our nurses very well. They are taking extreme measures to make sure that they're healthy, because they don't want to transmit or take anything to you. Now, the other thing is, even if you have concern there, my biggest concern is I'm more concerned, again, with you missing your medicine. That is not acceptable. Your drug levels go low. It may, it's hard to get it rescheduled, further delay. We don't want you to miss your medicine, because you're, again, more likely to flare than you are, in my opinion, to catch COVID. So do whatever you can to maintain your infusion. Your concerns are valid, and don't feel ashamed to ask your nurse. They want to reassure you, and they probably will before you can ask that. Yes, we're taking measures, we're wiping things down, washing our hands, protective gear.
Related, because when I was at my infusion center yesterday, there were a lot of masks, and there feels like there's a lot of confusion around masks. Do you need to wear a mask to an infusion center? Do you need to wear a mask in the world? Do they help? Do we specifically need to wear masks? What's the deal with masks?
I've seen so many funny memes for masks these days. It's hilarious. So there's N95 masks, and then there's other masks, surgical masks, paper masks. N95 masks have filters built into them through the fabric of the respirator that can help block the coronavirus into your respiratory tree, breathing it in. Then there's paper masks, and paper masks, regular surgical masks, they do not block, they cannot filter out the virus. However, there is a purpose. If you are sick, right? That's why we see a lot of just, lay people wearing them sometimes, right? They're sick, so they don't want to transmit it to other people. And likewise, healthcare workers don't want to be contaminated, some barrier protection. So N95 masks are useful for individuals who are more likely, okay, and a greater frequency to be exposed to a COVID population, okay? That would be healthcare workers. I personally do not believe there is much utility in N95s for lay population, because you're probably socially isolating, right? Socially distancing. You're home, so that's actually an N95 that you will not really need because you're not getting exposed. Unless you're, and also it's an N95 that we could give a healthcare worker, right? So they can take care of patients. So paper masks, there is a utility to wearing them. You could wear one just to prevent yourself from transmitting something to another person as a patient, even if you feel well. But I think what's more important is our healthcare workers actually wear the masks themselves, so that they can have some type of barrier protection, so they're not transmitting it to more patients.
So you don't need to, but can't hurt, right?
Don't need to, can't hurt, but I wouldn't go crazy for an N95. I really wouldn't, because you're not likely to be exposed to that population in your own home or in your own area, as long as you're isolating, right? If you're in your own home, you probably are not getting it. But the N95s, we really, until mass production occurs, we really need every one of those for the patients for the individuals who are higher risk to get them. That's your healthcare heroes that you see every day working in the hospital.
Think of your house as your built-in N95 mask, right? Just stay in there.
Yeah. Again, prevention, right? I mean, this is great, right? So to stay home and it's kind of cool, right? Everyone, I don't know, how have you been dealing with social distancing?
I am an introvert, so I'm not having that difficult of a time with it. I work from home. I like being home. I feel like I'm going a little stir crazy. I'm not gonna lie. My husband's home now too, so that's different. It's just knowing you can't right now. It's not even so much that I need to or want to. It's just when you can't do something, you want to do it even more.
Yeah.
But we take a lot of walks. I've seen a lot of people walking. I colored on the sidewalk yesterday. So just trying to just do stuff that you can do and dealing with it,
Yeah. I think just as not to distract us too much, I think in some, people are getting stir crazy, me too. At the same time, I feel like it's helped me. I'm pretty busy. I'm more busy than ever probably, but it's also provided me a way to kind of get in touch with things, a little bit more with nature, a little bit more to enjoy things I wasn't necessarily doing, spending more time with my family, even though I might be working from home when I'm doing telehealth and not doing procedures. I think it's kind of been a beautiful thing, actually. So I know everyone's getting stir crazy out there, but I think there's a lot of good that comes from being able to be at home and enjoy these things, because rest assured, we will go back to what was the normal way of life. This will be our new normal for now, but I'm quite confident we're going to go back to our previous normal. And when we do, we're going to realize the things that we might have taken for granted. right? So this is actually a scary time, but it's also a special time. And that's how I hope everyone looks at it too.
I think we're all going to slow down. I don't know if we're going to stay slowed down, but I kind of hope we do. We got a question on the live feed about the pneumonia vaccine right now. Do you know, is there any evidence right now that the pneumonia vaccine is helping those who are immunocompromised have less of a severe case?
I think it's a little too early. So just so you guys know, when COVID does, it's significant, it's severe, and it causes this viral initiated infection. Secondarily, there can be a complication of a bacterial pneumonia. So you have a viral induced pneumonia and then a bacterial induced pneumonia. It's suggested that having those who were vaccinated for pneumonia vaccine might be able to fight that off better, or not to succumb to that aspect of the infection. But the truth of the matter is we don't know, right? And everyone's different. So that what I said applies to kind of the general population of patients that was infected with COVID, had viral pneumonia, and then got bacterial pneumonia. How it applies to IBD patients, we can't say. Remember, we only have 41 cases worldwide, right? Worldwide, only 41 cases. What I can tell you though is certain immunosuppressants and biologics do warrant a prophylactic pneumonia vaccine, a 2-series vaccine, particularly those on anti-TNF medicines. I hate to use brand names, but infliximab, adalimumab, or certolizumab, which are, or golimumab, which are commercially known as Remicade, Humira, Cimzia, or Simponi. So that class, there's a slight increased risk of pneumonia. So we do recommend, even before COVID, that you get a pneumonia vaccine. We can apply that logic to some of the other biologics too, not all. So pneumonia for COVID, I wouldn't rush to go get one. Pneumonia because you are on a systemic immunosuppressant, that's a better reason. Talk to your doctor, your IBD specialist, and they'll tell you if it's right for you.
I know that we don't know a lot of things at this point. It's new. We're still working on research, for all the reasons that we don't know things like vaccines and everything. Do you think that we will know more in enough time for it to make a difference? Or do you think we'll know enough maybe in the future? Where are we on? What do you think timelines are in terms of research right now?
So there's a couple of things in terms of research, or in terms of vaccine research, you mean, or treatment?
Well, there are two separate questions, I guess, but both, right? I know vaccines take maybe about a year, right? Some people think we can get sooner, but about a year in most cases.
I want to qualify this. I'm not an epidemiologist. I'm not a vaccine specialist, but I do follow this closely because it affects my patients and it affects my family and my friends who are working alongside the hospital with me. We believe, what we're told is that it can be 12 to 18 months before we can see a vaccine that has been trialed and tested and has efficacy. And there are at least, one or two that I know of that are being tested. But just because you have a vaccine, you don't know if that's going to give you, if you give it to a patient, whether it's going to give you the robust protective capability that you want. So it has to be tested. And then once it goes through those trials, you have to synthesize enough of it, and then you have to make enough of it, right? So there's a lot of steps there. You asked an interesting question. You phrased it in an interesting way, which is, I think you said, will it happen quickly enough? Will it make a difference? And the answer is yes. It will definitely make a difference. Right now, COVID, we are not sure about the seasonality of the virus. We know that in the southern hemisphere, when it was summer the last few months, and they're just going into winter now, that they had cases of corona even in their summer, but that as winter crept up now, that there seems to be some more cases. So it suggests there's some seasonality. To me, it doesn't mean that this goes away when it gets warmer, right, in the northern hemisphere as we're going into our spring and summer. So it's still a question what seasonality is there. What it does suggest, though, is that, and I think Anthony Fauci, who is the NIH director of allergy immunology, and infectious disease, He was theorizing that we may see another cycle of this in the fall and winter. So research right now, the scientists around the world are conducting amazing research, high fidelity research on a very unprecedented scale. The amount of minds, the amount of diligence that is going into doing this is a Herculean effort. So we most definitely will develop a vaccine, and we most definitely will get the right types of placebo-controlled clinical trials done to get medications that work to fight COVID and the complications of COVID. But it will take some time, and I'm guessing this, next year, and hopefully sooner. But some people may say, well, that's not soon enough, and I would agree, that's not soon enough. But it's faster than you could ever expect for a virus this contagious. And because if it is cyclical, if it is seasonal, we don't know, but if it is, then yes, we're going to need these treatments. The research will be worth it. It will go on to save more lives, possibly mine, in the future. So the research is being conducted. It will happen. And if I know we can't wait a year or 18 months, it may be even sooner, but that is years before most treatments for other diseases are developed.
I will say that the concept of a vaccine being a year out, I think can be a little bit scary. But I wanted to relay that what I'm seeing specifically on Twitter, IBD Twitter, is watching our doctors, watching you and Dr. Rubin and all the other really great MDs out there working together. The togetherness, the global web that I have seen of doctors talking, the registry we now have for IBD patients, and it has been truly amazing to watch. And I have not seen this a lot in other disease communities. And I kind of wanted to just push that through to everybody again, is we have amazing GIs working with us and for us right now. You are one of them. And it is made me feel better. It feels like we're being watched, we're being heard, we're being looked out for. It's been truly amazing. If you're not on Twitter, I would recommend just checking it out just to see what's happening and seeing these really great doctors talk to each other about things as they're learning them.
Yeah. I'm a big fan of MedEd Twitter, and Dr. Rubin, Dr. Brendan Spiegel, all these wonderful doctors are doing a lot of education. That global map of just IBD patients was from the Secure IBD Registry. And I know Ryan Ungaro and Dr. Kappelman and another colleague, I'm blanking, I apologize, helped develop that database, but a professor from the University of Calgary is the one who developed that heat map. There are so many people collaborating. It's really a beautiful thing. It's just important, though, and more important than ever, that everyone watching this make sure that you're getting good, trustworthy information, because there's a lot of myth and misconception out there, especially about COVID, and it's creating so much fear. And yeah, we should be concerned, but a lot of these things are false. We're going to overcome this virus. We're going to beat it. There's no question. And Jackie, you said a year away for a vaccine might be a long time to wait. If maybe this is a glass half empty, glass half full. If we get the virus, we're more likely to have a mild course than a severe course. Okay, and that's how I look at it. But again, prevention. Distance socialization pays off.
So I have a question. This is actually kind of a personal question, but something I don't think I've seen answered a whole lot. Up until about a week ago, my husband was working out of the house. And something that we talked a lot about was, let's say he brought this home and he started displaying symptoms that were looking very like COVID. It's very difficult to get a test right now unless you can confirm you are with someone else that is positive. A lot of doctors are telling you to stay home right now, even if you are confirmed, stay home while you can. Let's say you're me and you're immunocompromised and your spouse is told to stay home, even if they are positive. What do we do? Do we move out? Do they move out? Do we bang the doors of the ER, tell them we need them to get in there? What do we do?
Yeah, I think that's a really hard question for me to answer, to be honest. healthcare workers are dealing with this too, even if they're not infected, just trying to isolate themselves from the rest of their family. But this is a particularly poignant situation if you have IBD and your partner doesn't, but they bring it home. So one, we encourage people who may be showing signs, okay, to get tested, because we can't predict what their disease course will be. So we need to know if you're not doing as well as we'd like and you test positive, we need to take you seriously and take you out of quarantine and bring you to the hospital and put you in quarantine and treat you there, right? If it's a mild course, let's say, okay, still get tested, in my opinion. Just because we have a shortage of tests, I find it hard to tell people, well, you shouldn't get tested, okay, if you have a risk factor, right? And we're getting more tests, right? A lot of biotech companies have put in, this was not their field, but they took their ingenious minds of their scientists and their technology and have made tests happen. And we need to go through more, quality controls for these tests, but they've made the tests happen. More tests are coming, certainly not quickly enough, but tests are available. So don't let that be a reason that you don't. Call your doctor and ask your doctor how you can get tested, because you're going to need their prescription order for a lab test anyways. Now for you, as a patient, I would recommend, isolating. If you can go, to another family member's house, we want to be practical. We want people to socially isolate themselves, but if you can be in another environment, for 2 weeks, that would be best. It's hard. If you can't, you don't have that luxury. Mom and dad aren't around, family isn't around, no cousins, everyone's too far, then you have to try to have boundaries, right? And you might be providing stuff and being the caretaker just so you don't get infected, right? Bringing them food, bringing them supplies, right? Again, everybody's different with their housing situation, so it's very challenging. If you do find that, what's the next thing you do? And by the way, even if you're not in that situation, you're just at home, right? Wash hands, right? Soap and water is such a powerful disinfectant, especially for the virus. So soap and water, 20 seconds, you've heard it, sing happy birthday twice, will help prevent you from getting it. Don't touch your nose, your eyes, your mouth, everything that you guys have heard us preach.
You mentioned, let's say you have to go be the caregiver, you have to bring the food in, maybe you live alone. You collaborated with one of our friends, Natalie Hayden, on an article earlier this week or last week about how to do that. Is it safe? Can we go out? Should we go out? If we do, how do we do it?
Yep, that's a great question. And I'll just kind of flash this for our colleagues to see here. But this is the article, and Natalie, went shopping, and she'd heard that several stores had been offering hours earlier for their elderly or at-risk patient populations to go shopping. So early hours or later hours, mostly early hours. And you can read about her experience there. I encourage all our patients, to take advantage. I would actually call the store in advance, call your local grocery chain, make sure you know their hours because they've probably been adjusted, explain your situation. I actually went to my Costco and my Acme, and I kind of asked in person as if I was a patient, and they were very compassionate. I told them I wasn't a patient, so I'd be honest afterwards, but they were very compassionate, and they said, no, we understand, there is an honor code here, so I would take advantage of those only because you have less numbers going and we just don't know enough. Again, I think that being on any immunosuppressant, you acknowledge that. I don't think that it should scare you, that you should live in fear to go out. You need your food, you need your supplies. Two, you mentioned that if you can't go out, or if you don't have a friend, right, or family member, right? I have been so unbelievably heartwarmed. There are little, people popping up all over the country making programs to kind of help the elderly, or to help people who might be in a certain situation. I'll give you an example. This is actually out of Chicago, a young man who developed this Leave It to Us. It's for seniors, actually. This is the young man right here, Michael Arundel. And basically you send him your order and he'll go pick it up. Not just him and a group of friends and volunteers, but I see this kind of movement happening in cities all around. So stay tuned, because I wouldn't be surprised if your local city is developing such type of services, mobile delivery services.
I have been similarly kind of shocked, but also like really renewed faith in humanity of seeing some of these things, community pantries, people willing to shop for you, people giving away their supplies. You just kind of have to look for it. And I think it's there. It has been kind of amazing. Okay. So let's say the worst happens. You have IBD and you test positive for COVID.
Mm-hmm.
What do we need to know, or like, how do we get through this?
Well, it depends on how sick you are and what's going on. But first thing is, you're going to be calling your doctor, and they're going to be determining whether you're going to be staying at home or not, right? Again, if you have it, I want you to if you get it, take a big deep breath. It's more paralyzing to think about the fear, right? This has created so much fear. But again, most people are not succumbing to this, right? And although we're early in reporting IBD patients in the world, only 41 so far, which is a good thing. So if you end up testing positive, take a big deep breath, be calm. Don't stop your medicines immediately, unless if you're very sick, you're probably in an ER and the doctor's going to tell you what to do there. Call your doctor, call your IBD specialist and your primary care doctor, and they're going to tell you what to do, okay? Main things about any viral infection are supportive therapy. Drink fluids, water, 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 water. Just like Mother Earth is mostly blue, you and I are also mostly made of water. So if without that, you've been seeing me I drink 4 of these a day. There you go, my buddy. So, I hydrate all the time as much as I can remember, but we need water to function. So the better hydrated you are. 2, Tylenol is okay. Although if you're not having a fever, don't take it, because you don't want to mask a fever. Okay. And we also kind of want to know, if you haven't been diagnosed yet, how high your fever becomes, right? 3, we believe for now that you should avoid NSAIDs, or non-steroidal anti-inflammatory drugs, especially ibuprofen for now, that it might be detrimental or promote the infection. Still, shaky to me, but that's our thing right there. And then 4, maintain some nutrition. I don't know about you, Jackie, when I feel ill, I don't want to eat or drink, kind of feel crappy, but force yourself, broth, what you would do in a flare.
Yeah.
Right? What you would do in a flare. IBD patients know how to survive anything. And if you know how to survive a flare, you're going to be able to get through most mild or, infections of the COVID virus. Or sorry, of the coronavirus illness being called COVID.
all the things. So kind of wrapping up some of our we have some other questions to get to, but I kind of this was a good time to talk about how do you manage the panic, the stress, the fear? Do you have any tips about anxiety or around this?
I'm joking, but I'm not. So breathing, meditation. I have not traditionally been very good about meditation. I'm not regular, shall I say. Healthcare professionals were kind of in a lucky year, because many people are offering healthcare professionals some free programs for clearing their head. I use one called Headspace. But for anybody, you can find so many programs for free online about how to meditate, how to relax the body. Also, exercise. Exercise, you're going to hear about us all the time saying it's good for the body, good for the soul, releases natural endorphins, helps you feel better, releases that stress that you may feel, okay? And then also the whatever you love, right? Some people, have certain hobbies that they don't get to normally do. Well, guess what? You got a whole lot of time, right? I used to be a magician. Right. I used to be a magician. Did you know that, Jackie? I used to do magic a lot, right?
I had no idea. I'm going to need to see some proof of that.
Well, Well, I'm okay. I used to be much better back in the day, but now I've been finding a little bit of time here and there to kind of bring out my magic skills back and practice a little bit. Not a lot of time, but just trying to find an outlet. Whatever you love, guess what? Now you got time to do it. So it's an opportunity. So how to combat stress and anxiety? Recognize the issue. Don't be less fearful. All right. Less fearful. We are going to get through this. I assure you, we are. Okay. No matter what happens, we're going to get through this. And the best thing you can do, isolate yourself. 2, meditate, relax. 3, exercise is a great way to relieve stress. And then finding that passion or that hobby that you've forgotten, reading a good book, Netflix and chillax, whatever it might be, that's your outlet. And that's what you can go ahead and sink into and relax.
We've got a question on our feed that is, do we go in for regular lab work or elective procedures, or is this, again, talk to your doctor?
Talk to your doctor. So elective procedures. So elective means that they don't have to be done so urgently and they can wait a little bit, So your doctor, I guarantee you, is making those decisions right now already, last couple of weeks, what cases to do. So fortunately, unfortunately, I've had to delay many patients' elective procedures to a later date, simply because we wanted to get a better control on this and make sure we had the right precautions in place before we bring them back. Certainly really urgent things like draining an abscess or a surgery that couldn't wait anymore, right? Those are exceptions. Lab work. Look, I believe that one of the most common causes of anemia in IBD patients, outside of the IBD itself, is too much blood work, okay? It's like you're not the blood bank, right? So this is a great time that we're all learning to really do more with less. So most of us are minimizing the amount of blood that we really need to draw. That's what we should be doing anyways, and drawing out the intervals, okay? Lab centers where labs are drawn, there's many different chains. They all have their own different protocols. So what I do recommend, if you have to go in to get labs done, so if your doctor wants labs, get them done, okay? What you do is you go out prepared. If you have gloves, use gloves. If you have hand sanitizer, use hand sanitizer. What do you do if you don't have those things? Wash your hands, soap and water, so much more effective. And if you have some tissue sanitizers, Lysol, Clorox, one of those types of bleach sanitizers, take those with you so that you can sterilize any surface that you have to come in contact with. Again, we should not compromise the quality of your medical care. If your doctor knows this, and your doctor will help you make the wise decision. So if they don't want to make you come in if they don't have to. So if they do request something from you, have the discussion with them, express your concern, let them explain their rationale so you're comfortable with it. But please get it done, because it's probably an important thing that they're asking you to get done.
Dr. Nandi, you have been a wealth of information. Is there anything that we missed that you are like, I just think you guys all need to know X?
Yeah, I want to, one reason why I'm here on social media is because I'm really sick and tired of people taking advantage of our Crohn's and ulcerative colitis patients. I'm sick and tired of it. I really am.
Here.
And there's a lot of people out there, even in this crazy world right now, who are trying to do just that, not just against IBD patients, but patients who are living in fear of COVID. So there's a lot of horrible quackery type of cures being peddled, all sorts of fakeness. And if it sounds too good to be true, it probably is. If you see something and you wonder, copy the link, share it with your doc, get their advice and their opinion on it. The best things to do are to promote, reinforce your own and reinforce others' ability to socially distance or distantly socialize from one another, so that we can slow the spread and take care of those who are very ill and preserve the health and well-being of our healthcare providers who are there on the front line. So beware of quackery, and please distantly socialize as best as possible.
I think the other two big takeaways that I want to hit home, reinforce is don't stop your medication unless you talk to your doctor about it. And 2, talk to your doctor about everything, every question, every decision. Call them, video chat with them. At this point, I think our doctors, even though they are busier than ever, they're arguably also more accessible than ever. And now is the time to really work on connecting with them.
Absolutely right. That's right.
All right. Well, before we head out, I want to sincerely thank you, Dr. Nandi. I know things are just bananas out there and you're busy and this is your free time and you're spending it with us. And thank you so much for sharing your knowledge and your time.
It's my pleasure. Thank you for having me. I really appreciate it very much. And I wish you, Jackie, your husband, Galley Health, and all our viewers this evening and going on, I wish you all the best and well-being.
Thanks. I also want to help our friend, or I want to thank our friends at Galley Health. They gave us this great platform to talk and to share information. And don't forget, they are launching their new newsfeed on their app for specific information about COVID-19 and how it affects IBD patients. Look for that coming up soon. This interview with Dr. Nandi will be on there. And I think that's all we have for tonight. Have a great night, everybody. Stay safe. Until next time.
Thank you.